Okay, so this section, we're going to look at positive risk-taking, and it's a new model that came in a little while ago. And obviously, positive risk-taking it can be a real ethical dilemma. Okay, so what do I mean by an ethical dilemma? What's an ethical dilemma?
Is it when you feel if something's right or wrong and you have to make a choice over it?
Kind of, yeah. So we would use the framework, the ethics framework. So we might use the 6 principles of ethics. So we look at, I'm doing no harm. So is what I'm doing a benefit to the person? So that helps me come to that process. We've got the non-malevolence and non-benevolence. So I'm not going to do any harm. I use the virtuous framework. So I'm going to be open and honest and transparent with that person. I'm not going to lie to them. The problem is, do my values and my belief system alter the way in which I'm going to look at risk? Okay, so risk adverse is all about how we think and feel as individuals on how we're going to look after other people. So for example, what if I went through all of you now, what is the most dangerous thing you have ever done, hobby-wise or an activity? So if I start at the bottom, Lou, what's the most dangerous thing you've done that you're happy to share?
Birth.
Birth. Okay.
I've had 6 children and I've had quite traumatic births with them.
Okay, so you've had 6 children, and I'd be right in saying that you were told by the hospital not to have any more because if you did, you could hemorrhage.
I was actually told that I could die, but I hemorrhaged with 5 out of 6 and I had retained placentas. So, yeah, I was told on the 4th one that I shouldn't have any more and I continued to have another 2.
Yeah. So, okay, so that's a great example of risk-taking. So you were told, don't do it. You were told the consequence of doing it, but you still went ahead and did it. And the reality is you had a reason for why you wanted to carry on. But if you said to me, Steve, you can't have any more children, I probably would have stopped at that advice and guidance because I would have felt that risk is too much for me to take. But had I have done that, then I probably wouldn't have experienced more children. So we can see there that that's quite a useful one. So Samantha, are you still there? Or are you able to talk?
Yeah, I'm still here.
Yeah, so what's the biggest risk you've taken?
Probably skydiving.
Skydiving, fantastic.
Yeah, and I've done it twice.
Completely unnecessary, isn't it? We don't need to jump out of an aeroplane.
No, we don't, no.
But okay, so you did it. Did you enjoy it?
Yeah, I loved it.
And was you told all the risks?
Yeah.
And you were told you could go splat?
Yeah, my biggest fear is that the parachute doesn't open.
Okay, lovely. But you did it anyway, regardless. Yeah. Okay, so who in the room would go, no, I'm not prepared to do that. It's not much.
But didn't do it.
Yeah, exactly. Okay. Clara? Oh, you're on silent, my lovely. No.
If you go Clara then. Yeah.
I think she's busy. Theodora?
Coming here, go abroad, obviously it's a big risk.
Yeah, absolutely. So do the benefits outweigh the negatives?
Definitely, because I'm in the green pasture here.
Yeah.
Obviously, take my family here as well to have a better life.
Okay, lovely. And Karina, what's your biggest risk?
I don't know how to say. I was expected of having cancer and I really didn't want to believe. I said, I'm not going to the test, but in the end I went.
Okay, so almost a risk for your health, going, I don't want to know. So
yeah,
all of you then have given really good examples. It's probably only fair I share one. Mine's deep sea diving. My biggest risk was I went 40 meters down to a shipwreck and I ran out of oxygen at the bottom. That one was a bit scary. And I knew it was a risk, but I still did it and I ran out. And luckily, your training all kicks in and it all goes in slow motion, and I was able to share oxygen from somebody else. So the reality is we all do things that we would be looking at each other going, that's mad. Why would you do that? And that's our value and belief system, which makes us different. So the problem is, if I'm behind something, I would tell you all to go deep sea diving. I'm sure Sam would go jump out of an aeroplane. It's fun. We're all going to do things that we're behind. And actually, if we're risk adverse, we don't like the idea of something, we're not going to be supporting it. And the problem is that becomes really difficult because we're managing people's lives, aren't we? When we're care planning and we're looking at risks, we're looking at things there. So just for a minute then, I want you to think about, in your care home, what could be the risks that people could take, but we don't let them take? So in your care home, what do people do or don't do, sorry, because of risks?
Let them out the front door.
Okay, so that's a risk, isn't it? If I let you out the front door, what is likely going to happen? You could get lost, you might get run over, you might fall. Is there a way in which we can manage all of that?
Yeah, they've got
With them.
rules in place.
Okay, so if I go with them, I'm still restraining them, aren't I? I'm still, because you can't do it unless I go. So what else could we do to give people independence? If we were to manage that risk?
Use the garden.
You might, but I want, let's say I haven't been outside the front door. I want to go to the corner shop to buy myself a newspaper. How could you manage that risk to make it safe?
Maybe they have this tracker.
Yeah, so you can have a tracker. So if you're wearing a tracker, I know where you are. I can keep an eye on you remotely. It is still a restraint, a tracker, because it means I am watching you, but I'm promoting your independence. Equally, I can have that equipment on you that if you have a fall, it notifies us and we can come and manage that situation. Thirdly, we did say, look, we could follow you or we could go with you. So you can still do it, but you're not doing it without me there. So we've still got the risk of you going out, falling over, doing stuff. But actually, what is the risk if I don't let you do it? What's the harm if I don't let you go out the front door?
You become aggressive.
So I could become aggressive. That's one. What else?
Withdrawn.
Yeah, so I'm going to start to become withdrawn. I might feel intimidated. What else is going to happen? Imagine if you haven't gone out your front door for years.
They're still going to try to go out the door.
Yeah, absolutely. So I may do it, but now not do it safely. So,
upset.
Yeah, good. So we're starting.
Anxiety.
Yeah, good. So we're starting to think a bit more now about risk versus benefit and consequence. And that's where we need to be thinking. So I'm going to give you another example, a bit more related to mental health, because obviously that's my background. So I'm a self-harmer and I want to cut myself. Are you going to stop me? Or are you going to let me do it?
Let them do it, but show them how to do it safely.
Okay, so I've got one person saying let them do it, but do it safely. Anyone else?
They encourage not to do it from a distance.
Okay, so you're going to encourage them not to do it from a distance. We've got two opposite ends of the scale there of an answer, haven't we? Does anybody else want to chip in? So I'm going to sit there, I'm cutting myself. Are you going to let me do it? Or are you going
I'd let you do it.
You'd let me do it? Okay,
It's
this is
like-
quite a controversial
We will do
topic.
it together. We will
Sorry?
do it together.
We do it together.
Yeah, so at least
If they don't
You're
do
going
it
to
in
cut yourself as well.
I should.
That's very kind of you. I probably don't need you to do that.
If you try and
Okay.
stop them, they're going to try and do it later anyway.
Yeah, okay. So what we're doing now, we are now really thinking on risk level. The risk is if you do it, unsupervised, and I think this is where Theodora was going, if you do it unsupervised, the risk is you may actually harm yourself. You may accidentally cut too deep. You could get it in the wrong place. I think that's what Louise was saying. She would let you do it, but with supervision and the advice on how to do it properly. Now, I know when I've had this discussion with other people, they're like, what? You would let them do it? You wouldn't stop them? As Sam said rightly, people are still going to take that risk anyway. You can't stop behavior. You know, we can't tie people up. That's not what we do. If I stop you from doing something, I'm taking away control. I'm taking away your fundamental right to live and make choices. It doesn't sound a big deal, but actually our whole society, our whole ethos of nursing is built upon this concept of equality and balance and rights and choices and promoting independence. Therefore, it's unethical for me to take that away. What I can do is psychoeducation. I can support you in understanding. If I try to stop you, as we've said, if we put a lock on the door, how many times do your customers go to your door and try and get out? It doesn't stop it, does it? It just builds up that anger. But if we talk about risk and we start going, well, okay, look, if you do this activity, this is what's going to happen. And again, we can try and talk people around. We can definitely say, these are the risks of you doing it. If you do it, this is what's going to happen. This is going to be the consequence of your behavior. So it's about that informed choice and decision making, isn't it? Equally, you will have others argue the opposite side, which is prevention is better than cure. Mm. So if we can prevent this from happening, why would you let it happen? So we have to look at what side of the coin of nursing are we on? Are we going to be the jailer, or are we going to be something that keeps somebody and promotes their independence? And a lot of the time in nursing, we end up becoming jailers and key keepers. You know, I'm locking you in, I'm taking away that choice, I'm telling you what you should be doing. And that's not at all any of our code of practice. Ours is all about promoting independence, promoting rights and choices. And we're allowed to make risks and we're allowed to take risks. And we have all today talked about unwise risks we've taken. So we do it. We just don't think about it when we're nursing in this way. So what we need to do is we need to identify that risks do exist and that they are harmful and that they can hurt people. That's the first part. Let's accept risks are there. The second thing about risk is to then work out, well, what can I do for you to still feel that your needs are being met, but we can do it safely? So, for example, I can give information, advice and guidance, as you said, Karina. I could support you, as Theodora said, or as Lou said, I could give you the education and do what you need to do. That way, you're still going to do it, but you're going to do it in a much safer way, and we've reduced the risk. So it's a bit like if you've all got children or you've had children and your kids go, I want to smoke or I want to drink, and you go, don't do it in front of me. Actually, if they did do it in front of you, you know they're safe. If you do it behind my back, I don't know what's going on, do I? So we always force this bad decision making, don't we, as parents? Because we always say, if you do it, I don't want to see it. So we're always saying, yeah, you can take the risk, but I don't want to see it. Actually, I think I'm going to be the other way around. If you want to take the risk, I want to be there with you so I can make sure you're safe throughout it. Yeah, it's a bit like that. So let's apply that back to nursing then. You've got an elderly lady. She's at risks of falls. What do we do?
Assist her and assess her if she needs any aid.
Okay, so we could look at equipment adaptations and adjustments. Yeah, so I'm not going to sit you down, lift a chair up and take you off your feet. I'm just going to go, how can you do this safely? So what can we do to assist people safely with risks? Because there is a module on risk of falls later on in this program for you. But what do you do in your homes? If you've got somebody who's a little bit wobbly on their feet, how do you still promote their independence?
By monitoring them.
By monitoring them? Yeah.
Making sure that they are wearing the proper shoes.
Good.
Walking aids.
Yeah, so proper shoes, walking aids. What else?
Ask them if they want to support on you. I don't know.
Okay, so they may want a chaperone or somebody, because again, walking is sometimes psychological, isn't it? It's the feeling and fear of falling on my own. If somebody's with me, I'm able to do it. Okay, so you're not going to use me as a walking stick, but I will walk with you. Yeah, what else?
Speaking to them to see what they actually want.
Yeah, so again, talking about environmental checks. So have I got, is the floor safe? Have I got any humps and bumps? Is there equipment or furniture in the way? Or alternatively, if you're going to do it anyway, can I give you hip protectors, which is like that padding that goes down their hips? So if they fall over, they're not going to fracture their hips. Or if they do fall over, it reduces the risk of a fracture. Equally, it may be looking at medication and compliance. Does medication make you feel a bit more sick and dizzy at certain times of the day? So what we're not going to do is stop somebody, because actually that completely demotivates them, can cause pressure sores and ulcers. But equally, the risk is if you do walk, you're going to fall over and fracture yourself. Neither's great, is it? We don't want you to have pressure sores, but we don't want you to get a broken hip either. But what we can do is look at what the risk is. The risk is risks of falls. We can look at all of the strategies and nursing interventions to reduce it and make it safe. And then we're going to allow you to do it. So the problem is it takes a lot of courage to write a risk assessment and risk interventions, because people will then blame you. My mum fell over, you could have stopped it. I don't think I could have. Unless I tie your mum up into a chair, I don't think I could have. We can have sensors on the chairs. We can have sensors on the floor. We can have movement sensors in the bed. The reality is, if mum wants to get out of bed, she's going to get out of bed, isn't she? Because I'm not going to put bars up, because that's going to be an obstruction. That becomes a risk hazard in itself. So we have to look at, when we do risk assessments, we have to think quite widely, which basically means if we're going to do something like this, we should have a risk assessment team or a risk panel. And what a risk panel does is it's a team of carers that come together and they look at what you have suggested and they review it. So it's not down to one person making the decision. So a risk panel is, you would look at the situation, you would see what the person needs to do, you would come up with the interventions or the nursing interventions, the strategies, and then the risk panel reviews everything independently away from what you're suggesting, because it's the panel that then go, yeah, you know what, this is a balanced approach. And it's those scales, isn't it? Does the risk outweigh the benefit? And actually, we need it to be roughly here. So when we look at it, we need to be looking at what's the harm, what's the risk, what are the nursing strategies, and do we feel those nursing strategies brings the benefit back up? And if it does, then all we can do is sign it off. But if it doesn't, then what else can we do to try and reduce that risk? It's too much and it's unfair to leave that to one person. Because the problem is, if one of us writes a risk assessment, and we're not talking about your normal 5-step risk assessment, we're talking about adverse risks here, we're talking about nursing interventions. If you leave it to one person, that's a lot of blame on that one person, isn't it? If you get it wrong, the inevitable part of these risks of harm is that the person does end up in harm, doesn't it? So it's not fair to leave that on one person, and that's why you have the risk panel, because actually the risk panel take that independent look. Does that make sense? Good. So let's just see what we've got here then. So a risk can be something with a harmful outcome. It could be from associated impairment. It could be a health condition, as Karina was saying. Sometimes you want to know stuff, sometimes you don't want to know stuff. No different if Bob wants his bar of chocolate and he's diabetic, Margaret wants her glass of wine but she was a recovering alcoholic, or Frank wants a cigarette and he's 92. All risks, aren't they? Do we let them have their chocolate and cigarettes, or are we going to deny them their chocolates and cigarettes? So it depends on what we're going to do there. And people will argue with you. People will say, but if that was me, I would want my bar of chocolate. If that was me, I'd want that cigarette. If that was me, I'd want that glass of wine.
Can you do these risk panels?
Absolutely. So you'd all sit down and you'd go, all right, so let's say Karina wants her glass of wine at the end of the day. I go, well, what's the benefit for her? Why does she need it? Can we replace it with anything else? And she goes, well, I've been drinking a glass of wine for the last 52 years of my life.
But can you do it just for one day? Like they've got really bad chest and you encourage them not to smoke or, I don't know.
You can encourage it, but are you fundamentally taking away their freedom of choice, which is a human right?
Mm.
So the reality is, what I could say to you is look, today you look really poorly. You know, I can see I've done your vital signs, your oxygen levels are really low. I strongly advise you not to have that cigarette. Inevitably, what do you think they're going to want to do? They're going to want the cigarette, aren't they? What you have to show, though, is that you took all of the, you gave them the right information to make an informed choice, and then ultimately it's down to them. Now, if, however, they lack capacity, then we would do it in their best interest, wouldn't we? So if they lack capacity, we could do a best interest risk assessment. I could say, look, Bob's got pneumonia, he's got a chest infection, he's really not well enough to go out and have a cigarette. However, what I could do is get him a patch. Yeah. So I'm not denying him the nicotine. So he's still getting the nicotine, but he's not getting it in that way.
Yeah, but is that only for the days he's got the...
It would only be, the best interest decision would only be for that one decision.
Yeah, but I mean, you do the risk assessment for only that month, for example, and then
for whatever that activity is, it lasts as long as that activity lasts.
Okay.
Yeah. So for example, let's just say I've got a chest infection and I've got pneumonia. Yeah. It would last for that period. So you would say, as the nurse in charge, you would say, look, Stephen's got a chest infection. We anticipate this to be 2 weeks. Therefore, he normally smokes, I don't know, let's say 5 cigarettes a day. Because of the chest infection, we've gone to patches, and obviously we've told him the risk and he can't plant blood. That would be fine, because what the law says is it is the most least restrictive approach for the least amount of time.
Yeah.
Yeah. Because I'm denying you your fundamental right to choose. Yeah.
How about the vape?
Yeah. Well, again, the vape, if you've got a chest infection, do you want to be inhaling moisture into the lungs? So if we think about pneumonia is fluid on the lungs. Those vapes are fluid. That's what you're inhaling, fluid. So you're just going to be putting more fluid onto the lungs.
Oh, okay.
Now, you might have the dry sticks, you know, those little pencil, the white sticks you get for smoking cessation. That might be okay. The last time I checked, now I don't smoke, but I have seen them in use. The problem with those is you actually need a good suck. You need to have a good inhale on those. And if you've got a chest infection, you probably can't breathe it in enough to get any therapeutic benefit. So again, we could say, look, let's give them the vape for the habit, that dry stick for the habit, but let's stick a patch on so we know they're getting the nicotine and they're not getting that withdrawal.
Mm-hmm.
Yeah. So we're still allowing you the nicotine. What we're just saying is you're doing it, but just not slightly in a riskier way, because we're not taking away your right here. We're just finding alternatives. Does that make sense? So again, if you wanted chocolate, fine, have chocolate, but do you have to have full fat chocolate? Could you not have the sugar-free ones? You know, is there a substitute to this? Can we find a middle ground? So the middle ground is that least restrictive approach. And that's what we're looking for under risk adverse. So again, if you wanted to walk, I'm not going to stop you walking, but I'm going to give you the right equipment, maybe hip protectors, and I'm going to get you your sensory stuff and the right shoes and mats. So it does take a bit of effort to get there, but actually what we end up with is a much more positive environment, because people are living much more fulfilled lives, and therefore they're not getting as angry, you know, as what they were. So, so mental health conditions, fine. Accidents, for example, is what's out in the community. So we talked about that, didn't we? We said, look, people are going to trip up in the community, but if you've got sensory staff or other ways of working, we've got those. Risk associated with impairments or disabilities. So here's one of them. People with dementia tend to end up with oedemas and swollen feet because they're wandering quite a lot. Do we carry on letting them wander in, or do we try and manage that?
think we're trying to manage that.
Yeah, it's that same thing.
Compromise.
Sorry, Lou?
Try and compromise so they can do a bit of wandering and then a bit of rest, and you know.
Yeah, so you might be walking with a purpose. You might be saying, look, what can we do for you? Where do you want to go? But can you stick your feet up for 5 minutes? So it's that kind of negotiation. Yeah. It'd be hard work. But the reality is, I'm sure all of you that work with dementia, you know you can't stop somebody from wandering. If they want to walk, they're going to walk with a purpose. It's our job is to work out what that purpose is. Where are you walking to? What are you hoping to achieve? Okay, use of medication, risk of medication. So we've got risk of people taking it, not taking it. We explain what it is. We look at what you can take. We look at what you can't take. And then we look at other strategies, don't we? We look at, okay, you can't take that tablet. Can you take that liquid? So the risk is still there. We're just finding different ways around it. Misuse of drugs and alcohol. Obviously, drugs is a no-brainer. We don't allow drugs in our services, even in detox services. So in detox services, you still get prescribed heroin and cocaine in the hospitals, but it's safely administered and it's under control as you detox slowly. Again, with alcohol, if you go to detox for alcohol, you're still given alcohol, but you're weaned off of it slowly. So again, the risk is, because people are always saying, oh, but if you give it, they'll want more, but that's not how it works, not in rehab. And equally with self-injury, people always go, but if you show somebody more images or if you talk about it, they're going to do it more. There's no evidence to suggest at all, if you talk about injuries or self-harm, it's going to make it any more impulsive. There's no evidence at all that suggests that. So again, we just look at those. Self-harm, neglect or suicide thoughts. So the risk of suicide. Does that upset anyone? Does anyone worry about patients with suicide? Is that a fear for anyone? No or no. So again, we all have suicidal ideation at some point in our life. All of us at one point in our life have probably said, I've just had enough. You know, it doesn't mean we're going to do it. Doesn't mean we're going to jump. It just means we've had enough. That's very different to somebody that's gone, I've got a date, time and place. So suicidal thoughts, if we don't talk about suicide, we make it one of those shameful things. We're meant to be lifted stigma. We want to get people talking so people feel that they're able to talk about it. Talking about suicide, again, there is no evidence to suggest it makes people do it. Actually, it's the complete opposite. Evidence is suggesting the more we talk about suicide, the more we normalise it, the less risk there is of people actually going to do it. Aggression and violence, so we all know, so looking at last week's session, we all know we're at risks of being hit. And we do a lot of the stuff, adverse stuff there, don't we? So we now know from last week's session, if somebody is at risk of harming you, what document should they have in place? What did I call it? What?
A crisis card thing.
Not the crisis card. Begins with P. It abbreviates PBS. Positive.
Restraining.
It was the positive behaviour support plan. Do you remember that document that looked at the risk? It did those 3 tertiaries. It had the images in the back. So actually, we've managed that risk, haven't we? You know, and there are, if somebody's pent up and they're angry, maybe there's things we can do to help them with that. And obviously, poor planning and poor service management ultimately is a risk, because if you've got managers not managing services, that can be quite difficult as well, because obviously, if you're short-staffed, that's a risk. Okay, but what's the risk if you don't? So the reality is it's quite easy to blame managers on this. Now, I've been a service manager. How many of you have worked short-staffed? I'm sure all of you, right? You have all done a shift where you have been short-staffed, especially over the last 2 years, right? So let's look at risk. If we work short-staffed, the risk is people don't get their care properly. People work under pressure. People can go sick. People high sickness levels. People leave the service. High staff turnover. Okay, that's all the risks. But what's the choice otherwise? I haven't really got a choice, have I? Because If I can't afford agency staff, then the business goes bust and nobody's got a job and we're all unemployed. People go without a home. So that's the poor planning part. So actually, why haven't I got a much bigger bank system? Or why can't I look at maybe some incentives? Or if I'm going to pay agency £15 an hour, why don't I have an incentive where if you do overtime, you get a bit more? Do you know what I mean? So there's things that we can do as service managers to try and balance that. So here, what we're saying is the type of outcome depends on the person, the relationship, and the circumstances they find themselves in. And that's why this panel is a really good idea, because it takes into account that holistic view. When you risk assess something and you look at risk aversion, you're seeing it through your eyesight. It's through your lens, through your thought, and through your belief system. By introducing this panel, it's now through a team of eyes, a team of lenses, and a team of experiences. Risk is often thought in terms of danger, loss, threat, or damage to equipment. It normally has negative connotations to it, but it can also have positive. So again, we need to think that risk is a positive thing, because the more risk I take, technically, the more I'm promoting my health and well-being, the more control I have in my life, the more enabled I'm becoming. But if I don't take those chances, I'm never going to be enabled, am I? So if I don't start walking again, I'm going to need care for the rest of my life, aren't I? But if I start to walk, I don't need necessarily all this care. If you give me my food and all right, I've got to do finger food, I can still feed myself. I don't need somebody sitting next to me feeding me. The risk is, okay, I could choke. Maybe I make a mess. But actually, I could choke if you're sitting there feeding me anyway, couldn't I? So just thinking about risk in a positive way as well can outweigh some of this negative thoughts around it. Risk can obviously be minimised by supporting others. So again, staff, family, friends, and we've just looked at that promoting independence. But it needs to be a balanced approach. It needs to be we need to look at the potential risks and the benefits of undertaking those tasks, okay? So the more you know about equipment, adaptation, changes to services, the better you are at managing positive risks for people. So managing risk positively, is weighing up the potential benefits, looking at the harms and looking at the choices that over others have, identify the potential risks involved, and developing plans and actions that represent this. So we're not asking you to do more care planning. We're just saying use the same thought process, the strength-based approach, use the same process through personal-centered care planning, through positive behaviour support planning. So whenever we do anything, it's a behaviour. We're not asking for more stuff. We're just asking people to change the way they think. It looks at positive potentials, priorities for the service user. It involves using available resources. And that's the other problem. It is a resource thing, isn't it? It's all right saying, have we got sensory mats and have we got this? But if your home hasn't got it, your home hasn't got it. So you can only work within your capability. And obviously what you're looking at is with the resources that you have to hand and the plans that you make, do they achieve the desirable outcome? Do they minimize any potential harm? It is not neglect, so we're trying to avoid the neglect of the potential risk. And again, we just need to demonstrate that we've carefully thought out the strategies for specific situations and circumstances. And that's obviously Stephen Morgan, 2014. So he was part of an independent review panel and he said, look, actually, we're not asking to do any more. We're just asking to think in a positive risk way. So the basis for this means empowering people, working in partnership with people for their own families, carers and advocates. And a lot of this is family members. So when family members go, why aren't you doing this for my mum? Well, because if I do it, I'm taking away her independence. I'm taking away her rights. Her doing it means we're promoting those. You know, why have you stopped, or why haven't you stopped my mum doing this? Because I think a lot of people seem to think as soon as somebody comes in your care, you're going to be shipping them around 24 hours a day, 7 days a week. And you're like, because if I do that, she's got no purpose. There's no hope. There's no recovery. There's no purpose to live. She's just going to sit there expecting everyone to run around her. You know, unfortunately in life, as we learn as children, when we learn to walk, what do? We fall over. We pick ourselves up and we learn, don't we? So we can look at a bit of Cole and Rogers or Freud there through learning. We obviously develop understandings of relationships with each party, helping people to access opportunities otherwise they wouldn't have had. Obviously, it starts developing trust in relationships, because what you'll learn as a patient is that I'm not here to be your carer. I'm here to be somebody that promotes your independence, that's trying to get you to do what you can. You know, the relationship is, I'll be here when you need me, not because you need me. And there's that whole Nanny McPhee thing going on there, isn't there? You know, I'm there when you don't want me, but when you realise, then that's when I'm going. And that's really what care is. You know, we're not, and we've been saying this since the 90s for as long as I can remember. You know, I'm not there to be your keeper. That's not what nursing is. You know, being kind, being compassionate, having courage is all about taking risks and promoting opportunities. The problem that you have is, if somebody does then fall over, all of that positive work that you've done becomes quite negative, because then it becomes your fault. But that's part of life, isn't it? You know, unfortunately, not every occasion it's going to work, but for the majority, it does. Understand the consequences of different actions, fine. Making decisions based on all choices available. Now, that's the most important part. So if we're going to talk about getting somebody back on their feet, walking, we're going to give them all that information. We're going to say to them, look, if you do this, this is the benefit. If you don't do this, this is the negative. But it's going to be impartial. You get to choose which way you want to go. Because the reality is, if you've been involved in safeguards where people have fallen over and people are accusing you of neglect, the neglect on the opposite side is much worse. So the neglect of pressure sores and moisture lesions and muscle deterioration and rapid weight loss or rapid weight gain, and that the anxiety and the fear of falling is much worse than falling. So there is so much more being pro-risk than pro-against risk. The problem is you just need to think about it quite clearly. And be positive about potential risks. So don't be negative and just say, oh, you know, this is going to be the worst case scenario. Look at that in a positive light and say, what can we do? What can we learn from this? Understand the person's strengths. Is it a nursing intervention? So it's called the strength-based approach. And under the strength-based approach, we're meant to be looking at what everyone can do and celebrating that and pushing it forward. So if you can still brush your teeth, then every day you should be brushing your teeth, because you can still do it. I should only be doing the bits in care that you can't do yourself, okay? And that does mean that sometimes it gets a bit more complicated, because when you've got people late stages and they're laying there and they're unable to participate in life, we've still got to be looking at the bits that they can do. Knowing what has worked in the past and what hasn't worked, so having that history there. Understand what problems have arisen and why, so looking at issues there. Ensuring support and advocacy is obviously taken throughout, and when things go wrong, who can they report to? And sometimes tolerating support short-term risks in concentration with services for long-term gain. So it's that short-term pain for long-term gain. So actually, you may find that you need to put a fair amount of work in at the beginning with somebody, but actually after a while they improve. And if you think about customers that have come into your care, if you're running a good service, I hope you will all have stories about how you had little old Margaret who come in, who was underweight and couldn't move, who within a couple of months had gained weight, was wandering around, all the pressure sores have been healed and all the bruises have gone. And they're the stories of success, aren't they? But at the beginning, you probably had to do quite a lot with little Margaret. You probably had to do a lot of, come on, Margaret, you need to eat that. Come on, Margaret, you need to do this. Come on, Margaret, we need to give you a wash. Come on, Margaret, we need to do this. But actually, once Margaret's understood her place and the benefits of all of this, she improves, she starts to improve. And you do see that quite a lot when people come into nursing homes. Sometimes they dip, but most of the times they kind of do that little roller coaster, don't they? They dip because they don't want to be there, but then they improve quite quickly because they feel safe, secured, loved, nurtured, and they can thrive because they're eating properly and the medication.
Routine.
Sorry, Louise?
And it's routine, isn't it? They like
Yeah, absolutely. So again, it is that it's just about providing a safe, cultured environment to kind of promote that independence. And it's a massive outcome, this. So obviously, once we've got the plan, we're going to review them regularly, gradually withdraw any appropriate services that they're dependent on. So we're not going to turn around and go, look, Margaret, tomorrow we're going to stop washing and dressing you. It's a gradual thing. Okay, so it's an outcome-based approach. Going back to those very first lessons, we obviously have to understand the different perspectives of adults. So we know that some people are going to achieve more than others, and that's fine. We're going to tailor this to meet your needs. We'll develop in personal-centered transition plans. So again, that's people either moving into services or moving out of services, because that in itself is a real culture shock, isn't it? Moving into a new home, where's the transition plan? You know, if you've met somebody in a different home, what did their day look like to what it looked like with you? You know, I always think in nursing homes or residential homes, if you're able to get yourself up, then really you should be getting yourself up. If you're able to give yourself a wash, you should be able to wash yourself. And really our job is just to provide that home around you. But I shouldn't be having to be knocking on your door, making you a cup of tea, bringing it in and doing all that, because that's a hotel. You know, I'm meant to be promoting your independence and getting you back to normal, aren't I? Nobody minds doing the nicety bits, you know, the kind bits. But the problem is when you look at staffing levels, you can barely meet the needs of the customers that need you. So depowering people and raising expectations where you can't give it doesn't seem right. And obviously manage staff where appropriate service users and obviously mental capacity, etc. So lots of benefits. Principles of working with risk. Obviously, identify, assess and manage, promote independence risks for adults with conditions, think about social inclusion, involvement, disabled, older people and people with mental health and problems. So that inclusion part, how are you going to make sure that everyone's being given the same opportunities? Risks change, so therefore circumstances change and it needs to be reviewed on a regular basis. Risk can be maintained, but is likely to be eliminated. So again, just be mindful of what the risks are and what you're going to do there. Information used and recorded will be as comprehensive and as accurate as possible. So again, just in care plans, just think about if people go up or down. Identify the risk criteria for the duty and the risk management, involvement of adults and services, making sure that you've got other practitioners involved, and improve the quality of risk assessments, risk management and decision making. But equally, if you have a decision making panel, all of that goes out the window because that's shared responsibility. Look at decisions and base those on looking at your local policies, procedures, and demonstrate clear practices and record keeping where possible and get some consent. Risk taking should involve everybody working together to achieve positive outcomes. We cover positive outcomes in the first month in module 1. Confidentiality is a right, but not an absolute right. So again, if people are at serious risk of harm, so you can't manage that harm, then you have a right to share. So here's one for you. And I'm going to use one that's been in the newspapers, okay? So imagine you're working in a learning disability service and you've got a gentleman, he's 21 years old. So he's at the peak of his sexual drive here. He's never had a relationship before and he's never had a girlfriend. For his 21st birthday, he asks you, can I have sex with a prostitute? So for his birthday present, for his 21st, he wants to have sex for the first time. So this has got ethical connections. It's got lots of risks. Are there safeguarding concerns here? Are there negative impacts? What do we think? What would you do? Anyone want to be brave enough to go first? And there's no right or wrong on this, and I'll tell you what came out in the case.
I think will be negative impact.
Do you think it'd be a negative impact? Okay, so if you were my carer, would you let me have sex with a prostitute or would you not? I'm not sure.
I don't know.
Because
I
remember
will
now,
check
we're
with
meant to
the
be
risks maybe, and
Yeah, okay.
choice.
Okay, so good. We're thinking about it. We're thinking about it.
Maybe using as some, how you call it? Condom.
Yeah, okay, so we're talking about condoms, so safe sex. Okay, so now we are thinking about risk and sex here, though, because the reality is I'm 21 years old. I'm entitled to a fulfilled sex life. I'm entitled to a relationship. Managing that has got its problems, hasn't it? It might feel uncomfortable having those discussions, but that's why CQC have made it very clear in the recent inspections they are going to be looking at your sex and relationship records, because they know this is an unmet need area. We're very good at washing people. We're very good at dressing people. We're very good at giving people something to eat. We're very good at giving people medication and food. We're not very good at fulfilling sexual needs. nor are we saying you have to, okay? We're not turning you into those workers. That's not what we're doing here. But there is an unmet need there.
You might be happy.
Very well could be happy. For my 21st birthday, if that was my birthday present, I probably would be very happy. Okay, so the question is, would you support it or not support it?
It's not like, sorry.
I would think to the risks and benefits, and then I will support with what he might need.
Okay, so we're going there. Sam, what was you going to say?
I was going to say, it's not like you can deny him his right to have sex, and he's never had sex before, but then it's not like you can supervise the sexual activity.
Okay, so now we're starting to think about the safeguarding and the appropriateness of it all. Okay, so basically what happened, this is a true story. The care home manager did indeed arrange a prostitute for his 21st birthday. He paid for it out of his money. So it was his savings from his benefits. Okay, so that's the first thing that I want you just to hold into your mind. The second thing was she felt it was safer to invite the prostitute into the care service for the intimacy to take place in his room, because ultimately it's his room, his space, and therefore if he called for help, if he hit the panic button, staff could go in and assist and help. So therefore she risk averted it. She thought, right, okay, this is what we could do. And then obviously, third of all, she gave him the information, advice and guidance about sex. She allowed him an opportunity to talk to his sexual health worker, and she provided him with the condoms and necessary equipment. So as far as the home manager was concerned, she was meeting his needs. So you'd think at this point, okay, fair enough. Where it all blew up was the fact that the public then got offended by this, because they turned around and first of all said, but that was benefit money being used for prostitution, which is illegal. So have you now actually just supported an illegal activity? Second of all, CQC were very unimpressed because the home is a regulated place where care and treatment is meant to take place, meaning there are other vulnerable people around. Was it appropriate to be bringing in somebody into the service where there's other vulnerabilities around? So that was the second problem. And obviously the third problem was, because she gave the equipment and adaptations, was she directly involved in aiding and abetting and promoting the activity? So what do we now think?
Yeah, now we can think of how you said that safeguarding.
Starts to look like a safeguard, doesn't it? Around sex and all that lot. So, okay, let's go back and think about Bob. We'll call him Bob. Bob, 21, he wants to have sex for his 21st birthday. What could we have done differently then so he could do it where it doesn't come back to us? Now, she did this all by herself, by the way. This was a registered manager who, quite frankly, I take my hat off to her because she was definitely trying to promote independence. But there were things that she could have done to avoid all of that backlash. So what do we think she could have done differently, learning from that lesson?
I think you have to look to his health condition as well to see if he's got capacity, if he can go out and on his own.
Right, okay, so that's good. So that's the first point. So he's got capacity, but could he go out on his own? So therefore, we don't need to bring it into the service.
Maybe we need a chaperone.
Okay, so we've got a chaperone just to make sure you're safe. We can be waiting outside, whatever it is, but I'm certainly not promoting it.
With a normal girl, not a prostitute.
If
I don't think that can happen.
Yeah, exactly. That might be difficult. The reality there is, I think it's illegal to pay for it. I might be right. I think it's illegal for a man to pay, but it's not illegal for a woman to charge. So under our prostitution laws, they were relaxed a couple of years ago. So it's not an offence for the woman. It is an offence for the man. Okay. However, if Bob wants to do this, what do I need to do first of all with him?
Make sure he understands.
I need to give him the right, so no, I need to give him the right information. I need to say to him, look, I understand that this is your choice, and I get that this is what you want to do for your birthday. Can we just talk about the risk and the consequences? You know, because if you've got capacity to do the act, you've got capacity to understand what we're saying here. We may have to break it down. We may have to put in accessible information, but we're going to explain this into a way where it's very clear. He still may choose that he wants to meet somebody. And okay, let's say he meets a lady in a bar. We just don't know she's a prostitute. What is he going to need to have on him ready in case he does meet somebody?
A phone.
So a phone.
Contact details.
Contact details. What shop may I have needed to have taken him to buy certain things?
To buy condoms.
There we go. So he could go purchase them. Now, if he had purchased them, what does that show?
That he's capable.
Yeah,
capable and consent. He's buying it because he knows what they're being used for. If I give them to you, you don't necessarily know what they are or why you're using them, do you? They've just been provided. Okay, but if I buy them, it alters the legal understanding of what's going on here. So we're still going to try and achieve the same desired outcome. We're just going to achieve it in a different way. I'm going to give you the advice and guidance. I'm going to take you to buy them, and I'm going to take you to the location. What you choose to do at that point is up to you. Yeah? Now, think about how that looks completely different to the manager going, I want to help you. You can do it in the home, and I'll provide you with all the necessary equipment. It now goes back to risk and choice, doesn't it? It was his choice. It was his risks. The other way round, it was completely promoted, wasn't it? This way round, it's completely independent. So we're achieving the same outcome, just in a very different way. And ultimately, if I were to write this all down in a positive risk plan, what am I going to do with it? Who am I going to go to once I've written this down as the manager? I go, look, I've done this.
CQC.
Could go to CQC. I could say, I can tell you what CQC will say. It's not down to us because they never answer anything. Think of somebody else. Think of internally. Think of on here. Oh,
Emily.
Oh, where did we go? Principles are working. Go back. We did that one. Where was it? Think of on here. Look at F. What's the last part of F? So what did I say? Once you've come up with a risk plan, what's the best thing to do?
Decide.
So
Decision making.
Decision making. So go to a decision making panel. Now it's no longer your responsibility. You've opened it up to a team of people. So therefore it can't be blamed that Stephen said, this was Stephen's idea, because under a safeguard, I need to be going, hang on a minute, I was promoting this individual's rights and choices, but what I did was I gave them the information. I didn't enable it. I took them so they were able to buy the equipment and make their own choices. I didn't certainly promote it and make it easy for them. They had to demonstrate that they were capable, and part of that decision making was they were able to go and buy the stuff and they were able to find where they wanted to go. Okay, it's not down to me to stop them if I felt that they were at risk. These were the decisions that they were making. And equally, the fact that they were able to weigh it up, buy the right stuff, demonstrated to me that they were able to make those decisions. I went back to a decision-making panel, and as a group of people, we had a discussion about what we thought about this risk, because it is a risk. That's a very risky activity. But we looked at what we thought would and would not constitute a conflict. Does that make sense? Mm-hmm. It really is just how you look at it. And when we think about safeguarding, we can make mountains out of molehills. But our job when we look at safeguarding concerns is to go throughout the whole process. Who's leading this? Where were the decisions being made? Who can we demonstrate that they were safe? Okay, so by it being customer-led, it's all safe, isn't it? You know, we were just providing them with the right information and the risk. Because throughout, we could have said, if you have sex with a prostitute, you could be arrested. It's a risk, yeah? Obviously, we don't know. People are entitled to their freedom, aren't they? You know, if he goes to college, for example, and he went elsewhere, what would be the risk if we didn't have those conversations? So what would be the worst case scenario as a risk here? You've got a 21-year-old who's feeling a little bit for the moment. He wants to have an activity with somebody. What would be the risk if we hadn't have done any planning? What could have happened? Think of the worst case scenario. You've got a 21-year-old boy, man at that age, learning disabilities. For his birthday, he wanted sex with a prostitute. If we hadn't have done the plan and all the interventions, what could he have done? Going back to what Sam was saying earlier, when people want something, what do they do?
Still, he'll carry on, probably make his own plan, not telling to anybody what he's going to do, then he'll be in a trouble.
Yeah, exactly. So the worst case scenario is he could have gone out and raped somebody, couldn't he? Mm. So we now start to think about risk in a very different light. So my argument would be, does our plan, does it prove safer than the choices that he would make? What do we now think? Is our plan sounding a lot safer than his plan?
Yeah.
Yeah, absolutely. We may not have enjoyed the conversation. It may have made us felt a bit uncomfortable. But the reality is, if we're dealing with working age people, this is an unmet need, isn't it? The need needs to be met, and it needs to be met safely. Therefore, the risk here is you're telling me you've got a desire to do something. If I turn a blind eye to it, I am forcing you into a much more riskier behaviour. By addressing it, we can look at safe strategies, safe interventions, and support you to make a much wiser choice. Happy with that? I know I've taken it to the extreme there, but it was in, there's a great article. I'll see if I can find it for you. It was on TV as well. It was in TV like 4 or 5 years ago. And this home manager, bless her, she lost her job in the end because safeguarding had her. Mm. But it came up to a massive argument, which was, did the young man have a right to his desire? And nobody could argue that he didn't. It just wasn't done safely. And the sad thing is this manager thought that she was working in a safe way. So the risk is if I do nothing, the worst outcome could be rape. I do something, it's all controlled. Ultimately, it's all going to be documented, isn't it? You know, because like Sam said, if somebody wants to do something, inevitably they're going to do it. It's just where on the framework are we going to say this was the support, this was the advice and guidance. Anyway, any questions on that? Are we happy with that? Does it make sense? Are we understanding the thought process behind risk?
Yes, I think that only the problem with the manager, I think it was not discussed to the risk panel.
Absolutely. And if she had a risk panel, somebody there may have said, I just don't think this is a good idea. You know, I'm not saying he can't, but maybe if we did it this way, it would be safer. Because she did it under her own right, it looked like a safeguard. It looked like she was trying to conceal something or hide something. We don't need to do that, do we? We're trying to have, so that's why each home should have a decision-making panel. Because the reality is these are ethical dilemmas, aren't they? These are things that we don't want to get caught up in, but we're going to get caught up in them. You know, for example, you may have somebody say to you, I want to go to Sweden to the suicide clinic. I've booked my ticket. What are you going to do in that situation? Do you have capacity? Have you got means? Yeah, I can fly there. I've got money. This is what I'm going to do. Okay, so the worst part here is you could go and do it. You know, so let's not hide behind things, because if we have an open door policy or an open culture, people are going to tell us stuff. It just gives us an opportunity to help them think through alternative ways or different choices. Yeah, happy with that? So the reality is, if you had the same question in your home, so if you go back to your home and go, so in class today, we covered this topic, what would you do? I bet half would go, no way. And the other half would go, yeah, no, I think it's okay. So the reality is, it just depends on your view, doesn't it? It depends on, imagine though, if you're Catholic and you have a strong belief system that no sex before marriage. So the first thing you're going to say is no, because you need to be married. Well, what's the chances of a 21-year-old with learning disabilities got to go out and get married to be able to have sex? So again, strong views exist. Strong views exist. No different to when you say to somebody, do you want that bar of chocolate? And they go, yes. And everyone's going, no, no, they can't have it. You know, strong views. And that's just over a bar of chocolate. But what I would say to you all of this, what would you want if you were that person asking? And if you go, I would want help, I would want somebody to support me, then you've probably answered the question. You just need to find, using risk management, risk-averse policies, risk-averse practices, how can you do it and do it safely? As long as it is not illegal. Okay, we're not offering, we're not saying we encourage illegal behaviour. We're looking though to promote independence and be non-judgmental, and that can be very, very difficult. Okay, obviously confidentiality, covered that. And members of the PCT board, and that's normally the, I can't remember what PCT, it's Primary Care Trust, sorry. So members of the Primary Care Trust board, counsellors, senior managers, healthcare support workers and staff will look at a guide of managing risk positively, and obviously you can follow those. And the reality is, if you do end up in advanced complex dilemmas, such as the one we've just discussed, you can obviously gain consent from the individual. Say, look, can I talk to your doctor about this? Can I talk to that person about this? You know, just so it's not you doing it on your own. Obviously, sharing of information is really important. You must have a framework for sharing of information, but normally people do that anyway, don't they? They sign the consent forms. The reality is, I think when we're looking at risk management and advanced decision-making, we need to look at risk in a very different way. And you may need to get a further piece of consent the reality is when we talk about sharing information, I don't think anybody would assume that in a private conversation where you're looking at risk that you're going to go around talking to everyone about it. So, you know, in that situation, I would always get consent for that particular risk to be shared, because they may feel ashamed or embarrassed or whatever. So just make sure that you're getting that. Obviously, risk identification, look at the risk, look at a balanced approach, look at what is not an acceptable risk. So as we said, what is an acceptable risk is putting somebody in a position where they could become a predator or they could hurt somebody, especially if it's something that you can do just to manage that situation. Not every situation or activity will entail a risk, but again, it should just be managed appropriately. And again, your risk assessment forms, whatever your risk process is, whether you do a 5-step tier process or you're just having a discussion about it, just make sure that you've taken into account what the worst case scenario is, and obviously follow that through. Remember, during the risk assessments, you need to follow the certain points there. So it's managing the views of the risk, the views of the individual, the views of the family, the views of the carer. Gather the information, so obviously informed choice can be given. Make sure that you're focusing on the strength-based approach, looking at all the positives, and see how that works. Have a person-centered approach, making sure that the individual is put at the center of obviously what's going on. Manage the risk positively, and again, you could be looking at a short-term plan. I think that's what Karina was saying, how long does it last? They're short-term, they're for that position, but if it's a longer-term thing, then obviously you could do a longer-term plan. But again, you would be tailoring that to the situation. And obviously, taking risks into account enables people to manage their lives with better control. In the Canvas app, I have given you a couple of risk management tools. So I've given you a couple of documents in which you can download, which runs through the risk management stuff. It's not like a risk assessment form. It's a bit more holistic than that. But ultimately, you need to make a risk management plan, be clear to the individual and clear to others. Every individual or agency should be involved. And again, that's what we're saying about going to the decision panel, because if you get it signed off, nobody can say that they didn't know this was going to happen. If anyone's involved in the care of support plan does not agree with the assessment, then this should be documented, because the reality is people will disagree. You know, not everyone's going to agree with the decisions we make, but there are decisions. It's our body, our right, our choice. We're going to make them. Obviously, if you've got any concerns, that should be reported. Any harm should be notified. And again, it doesn't actually change the decision-making process. It just happens to influence and come up with different things. And obviously, transition planning for children or adults into services just need a slightly different view. Right, review the incident. So once something's happened, obviously you would do a post-incident review. So did the plan work? Was the risk worth it? Did it benefit them? Or if something happened in it, what was the incident? What happened? And again, if it concerned them to a serious incident, obviously you have your duty of care to report. You may have to report it to the safeguarding teams. You may have to report to appropriate managers. And equally, you may end up with a duty of candor, so you may have to apologise. But ultimately, that's only if a risk is done and it wasn't followed through. You know, the reality is, if the person understands what the risk is and the consequences, then that is part of it. But you wouldn't necessarily hide anything. So if an incident did happen, so let's say Mary did fall over and she did break her hip, what the safeguarding team are going to be looking for is that you had the incident planned, you put all the necessary PPE in or recommendations to save them. And if the incident does happen, then it was just unfortunate, you know, because there's only so much you can do to safeguard people. Obviously, underlining principles there, then looking at a person-centered approach, we've got the medical model of delivery, and that's obviously where we prescribe things and we say what we think is right or wrong. We've got the social model, and again, that's just looking at inequalities. So if you think about this 21-year-old, he definitely fits under the social model of disability because he's being disadvantaged because of his disability and the choices that he can make. Because if he was able-bodied, he wouldn't need to be having those discussions about the choices that he wants, would he? So again, you could argue that there. But obviously, the person is the centre of the control. Family and friends are appropriate. You reflect upon capacity, share the information, and obviously just listen and liaison. You don't need to worry about that. Professional competencies, that's just about working in a multidisciplinary team. You're not going to worry about that. We're not going to do mental capacity. Data protection, we don't need to worry about. Neglect, so if somebody accuses you of neglect, neglect is a carelessness amounting to a breach of duty of care, so failing in reasonable situations to do something. The reality is, if somebody harms themselves, but you have planned for, so you've already given the information, you've got the risk assessments, and they harmed themselves, that's not neglect. Okay? Neglect is you didn't do it. So people can still get injured. It doesn't matter how good we are in life. We are able-bodied people. We can trip up our own feet. We're not going to sue ourselves, are we? It's just a matter of fact of life. As long as you have planned, as long as you've looked at the equipment or the adaptations, and you've got the right support in place, and this is why the decision panel is really important, it does not constitute neglect, because you have done everything that is reasonable and proportionate to keep that person safe. Yeah, happy with that? Oh, there we go, look. Risk enablement panel, so this is what we were talking about. Risk is part of everyday life. It's something that we need to learn to deal with. The idea of the risk enablement panel empowers people's choices, ensures that person-centered approach is being done. They have a real choice and control over their lives. This means that they take into account individuals' choices, family views, and staff, etc. And obviously, it is a belief system that decision-making is shared, it's transparent and safe, and it's the right way to reach the best decision for that person. So what I would say to you from today's training is go back to your homes and ask your managers, do we have a risk enablement panel? Because they may have one and you may not know about it. But if you haven't got a risk enablement panel, then how are you managing these really complex ethical processes? Yeah. So the risk enablement panel is that risk decision panel. It's what I said earlier. It's the panel in your work that come together to highlight risk, reflect upon it and go, what is right or wrong? Have we met the duty of care? Have we met all the safeguards? And they're not there to stop risk. That's not what the risk enablement panel does. They are there to promote positive risk taking. What their role in that panel is to simply make sure that all opportunities have been taken to reduce the risk. Yeah, does that make sense? And that is it. So you'll be pleased to know, everybody, because we've whizzed through that and we've not stopped, that's the end of today. I'm going to upload these videos. Hopefully you've got something out of that. I know it's quite a theory thing, but it gets us to think a bit more about the things that we can do. And equally, I'm sure you have all been in a situation where you've said something to somebody and you've been shot down, or you've disagreed with something that's happened at work and you felt that the person should be able to do it or shouldn't be able to do it. And it shouldn't be down to one person to make those decisions. You know, it is a joint decision, and that's what we're looking for. Strength-based approach, a positive outcome, and obviously the risk is shared, because it's not down to one person to say you can and can't do something. And just going back to that one for that 21-year-old, okay, just because it just popped in my head. Imagine you couldn't fulfill it. Imagine the panel did say, look, we can't fulfill this wish. It's just not in our capability. What could you have done as a reasonable adjustment? What other options could have been there? So we can't fulfill that, but what we could do is this. So it's gone to the decision-making panel. The enablement panel have said, nah, don't matter what way we look at this, we can't make this work. What could you do as a substitute? So it may not be the perfect response, but something better than nothing. No? Okay. So we could have looked at maybe, because he's 21 years old, we could have maybe given him the internet and maybe he could do a little bit of shopping online. Maybe he could buy himself something to help relieve himself. There could be materials that he could potentially look at or buy. Because again, if he was an able-bodied male or female, he could buy whatever he wanted to. Because he's in a care service, he's restricted to the access of what other people could buy. So again, just because we disagree with it or may not agree with it, doesn't mean that he shouldn't have the access to other opportunities. So if we look at the fact that it is a need that should be planned for, what could we do to fulfill that need? So could we buy equipment? Could he buy equipment online? Or are there images and materials or videos, whatever he could have had instead? And would that have been a safer option? And that really is why you would have that meeting to go, look, yes, we can do it. No, we can't do it. If we say, no, you can't do it, are we denying somebody something? And is that a doles?
Yeah.
Yeah, that's going to be an interesting write-up, isn't it? However, so nobody wants to write that one up. However, what the law says is we must find a reasonable adjustment. We must be able to do a reasonable adjustment, and it must be for the shortest period possible. So again, it might be the fact that we're going to start off in a different route. But the reality is, in each of your services, if you look at that sex and relationship policy, that's why it's there, because actually working age people, well, not even just working age people, I've known a lot of older people who have wanted to do things and we've had to go, no, she's a married woman, leave her alone. Bob, take your hands off of her. That's not your room. Yeah, we've all been there. We just don't talk about it. So we're smiling because we've been there, haven't we? We've seen it. Right, okay. So on that note, I hope that's given you something to think about. If you've got any questions, by all means, you can email them via Canvas. Remember, you've been sent the link for functional skills today. Click on the link, start that. Let me know when you want to do your assessments. And we're halfway through it, everyone. Yay, we're halfway, yay. And I will see you all next week.
Thank you.
Thank
Bye,
you.
everyone.
Bye, everyone.
Bye.
Bye. Bye-bye.